Hello, I'm Sanjib Majumder. I'm a consultant plastic and hand surgeon from Yorkshire in the United Kingdom. And for this Medicine in a Nutshell talk in our hand injury series, I'll be discussing ulnar collateral ligament injuries of the thumb metacarpophalangeal joints. The most common presentation of this injury is in an acute setting where patients give a history of a fall on an outstretched hand, the so-called Fuchs injury, causing hyperabduction of the thumb at the MCPJ, causing injury to the ulnar collateral ligament. This is often called a skier's injury because skiers would fall with the ski pole still in their hand, and the ski pole itself would act as a pivot around which the hyperabduction of the thumb MCPJ occurs. Of course, in the United Kingdom, we don't have much skiing, and most of our patients present with this injury with a fall on the outstretched hand without the exoticism of having gone skiing. Less commonly, patients may present with a chronic injury to the MCPJ secondary to repeated abduction stress at this joint. This is sometimes called a gamekeeper's thumb because historically gamekeepers would need to wring the necks of pheasants or rabbits which had been shot down during hunting to ensure that the animal was dead. This twisting mechanism and the hyperabduction stresses that it put onto the thumbs of the gamekeepers would cause stretching of the ulnar collateral ligament over time and result in an instability of the thumb at the MCPJ. For the rest of this talk, we shall be concentrating on the acute injuries to the UCL of the thumb MCPJ. Now you may be thinking, why is it we get so concerned about the ulnar collateral ligament of the metacarpophalangeal joint of the thumb, given that there are collateral ligaments in all the other fingers? Well, let's start by looking at the anatomy. Now, the most common way of visualizing a joint is by plain X-ray. And when one looks at the X-ray of a joint, whether that be of a finger or a thumb, they look pretty similar in structure. There's a bone at the distal part of the joint, there's a bone proximally, and a gap between the bones. Of course, just looking at it, this does not look like a stable construct, and that gap can't just be air. So let's look at this schematic diagram to demonstrate the parts of the joint that are not obvious on the X-ray. In the gap between the bones, there is of course the cartilaginous cap around each bone end, and then there's the joint capsule with the synovial fluid within it. And on either side of the joint, there's a collateral ligament, the radial and ulnar collateral ligaments, which give the joint lateral stability. Looking at this lateral view of the MCPJ, one can see that the ulnar collateral ligament is a fan-shaped structure and has two separate distinct parts. There's the proper ulnar collateral ligament, which goes from the neck of the metacarpal to the base of the proximal phalanx, so that is from bone to bone. And then there's the accessory collateral ligament, which goes from the neck of the metacarpal to the structure on the volar aspect of the joint, the volar plate. The volar plate is a fibrocartilaginous structure which, as you can see, spans the joint on the volar aspect and thus preventing hyperextension. Because the ulnar collateral ligament is attached to the volar plate, and very similarly there's a radial collateral ligament on the other side which is also attached to the volar plate, the three structures, the two collateral ligaments and the volar plate, form three sides of a box, conferring much stability to the joint. The collateral ligament can become detached distally, it can become detached proximally or mid-substance, or there can be an associated avulsion fracture when the bone breaks rather than the ligament avulsing off the bone per se. But these sort of injuries can happen at any collateral ligament at any digit, and most of these are treated non-operatively. So what is so special about the ulnar collateral ligament of the MCPJ of the thumb? The big difference is that at the ulnar collateral ligament of the MCPJ of the thumb, one can get what is known as the Stenner lesion. This was something described by Stenner in 1962. When one looks at the anatomy of the thumb MCPJ, one can see that close by there's a muscle called the adductor pollicis, shown by this arrow, and this muscle attaches on to the extensor hood by the way of an aponeurosis on the ulnar side of the metacarpophalangeal joint of the thumb. The adductor aponeurosis lies superficial to the ulnar collateral ligament, and the thing about the adductor aponeurosis is that it's got a free edge proximally. So if there's an hyperabduction injury to the MCPJ and the ulnar collateral ligament ruptures distally, it can, because of this free edge of this adductor aponeurosis, flick out from its natural position deep to the adductor aponeurosis and then come to lie superficial to it, as demonstrated in these two pictures. And when this happens, the adductor aponeurosis prevents the distal end of the ulnar collateral ligament from reattaching to the base of the proximal phalanx where it should normally lie, and as such the ulnar collateral ligament cannot heal, and there is an instability which then becomes chronic. The chronic instability then manifests as pain at the MCP joint whenever the patient tries to hold anything between the thumb and any of the digits, as in a pincer grip, and this can obviously cause functional problems with the patient's grip. This is the intraoperative photograph of a patient who was clinically suspected to have a complete rupture of the ulnar collateral ligament. This is the ulnar view of the MCPJ of the thumb, showing the adductor muscle, the adductor aponeurosis, the dots outlining the free edge of the adductor aponeurosis, and the ulnar collateral ligament sitting superficial to the adductor aponeurosis, the Stenner lesion. The diagnosis of an ulnar collateral ligament injury to the thumb MCPJ starts obviously with the history of the fall on the outstretched hand, as we've discussed previously. Patients complain of pain, swelling or ecchymosis on the ulnar side of the MCPJ, as pointed out by this arrow. There may be some radial deviation of the thumb at the MCPJ, and then one needs to radially stress the thumb at the MCPJ to look for stability. What you're looking for is an end point. If there is an end point, meaning you cannot completely open out the joint, it means that the rupture of the collateral ligament, the ulnar collateral ligament, is incomplete, what is known as a sprain. If there is no end point, that is, one can feel the joint opening up without obviously any end to that, then it means that the rupture is complete. The importance of examining per endpoint is that if there is no endpoint, that is to say that the ulnar collateral ligament has completely ruptured, it is then possible that the rupture has taken place distally and that the ulnar collateral ligament has flicked out from deep to the adductor aponeurosis and is sitting superficial to the adductor aponeurosis, that is to say that there is a Stenner lesion. And if there is a Stenner lesion, then it needs to be repaired operatively, because if it is not, the ulnar collateral ligament will not heal and there will be chronic instability and pain at the thumb MCPJ. Prior to examining the injured thumb, one must establish the baseline laxity for the patient, and this is important because there is a variability in the level of joint laxity between patients, and to do this one must first start by radially stressing the uninjured thumb MCPJ. The patient's uninjured thumb metacarpal is first stabilized by the examiner as shown in the picture, and then the thumb itself is stressed radially as in the direction of the red arrow to determine the baseline laxity of the uninjured thumb MCPJ. Then you go on to the injured thumb, and you can see the difference between the right and the left, where on the left side the thumb opens out almost completely on radial stressing. The dotted lines are parallel to the metacarpal and the proximal phalanx in both the uninjured and the injured thumbs, and one can see the difference in the angle that one can get on stressing of the injured left thumb compared to the uninjured right thumb. One should point out that for the sake of teaching perfect technique, that unlike what is shown in this picture, the examiner's hand which is stressing the thumb should hold the patient's thumb at the proximal phalanx and not at the distal phalanx. This is so that all the force is actually put through the metacarpophalangeal joint of the patient, and there is no force put through the IPJ of the patient. One has to ensure that the patient does not feel pain when the injured thumb is being stressed, and this can be done by putting local anesthetic at the site of injury and ensuring the thumb is numb before stressing. If the radial stressing is done under radiological control, one can see how the thumb opens out at the ulnar side of the metacarpophalangeal joint. This can be compared with the uninjured side. The left side in this case is injured and the right side uninjured, and one can see the differential opening up of the joint. It is important to remember to perform the radial stressing both with the thumb fully extended at the MCPJ and the thumb partly flexed at the MCPJ. This is because the accessory collateral ligament is on full stretch when the thumb is extended at the MCPJ. So if the thumb is only examined in extension and the accessory collateral ligament is intact, one might miss the proper ulnar collateral ligament injury because the presence of the intact accessory ulnar collateral ligament will confer some degree of stability. Plain radiographs are quite important in establishing whether there might be an associated fracture. Many times the fracture might be a small fragment such as this one, or you could have a much larger chunk which is compromising the congruity of the joint surface of the base of the proximal phalanx. There's some confusion and controversy in the literature about the situation where clinically there is a complete rupture of the ulnar collateral ligament, so one is wondering whether there might be a Stenner lesion, but a plain X-ray shows a fracture fragment like in this X-ray where the fragment is undisplaced. The concept here is that the ulnar collateral ligament, shown here in red, is attached to the avulsion fragment which is undisplaced. As such, it is thought that the ulnar collateral ligament will heal by non-operative measures because the ulnar collateral ligament is sitting exactly where it needs to heal, that is to say at the base of the proximal phalanx. As there is no gap between the avulsion fragment and the base of the proximal phalanx, there can be no Stenner lesion. However, there are numerous reports in the literature which confirm that one can have an avulsion fragment and also an avulsion of the ulnar collateral ligament from the fragment. That is to say that the position of the fragment cannot itself be used as an indicator of the position of the ulnar collateral ligament. And of course this means that the ulnar collateral ligament then can go on to a Stenner lesion, and if there is a Stenner lesion, it needs to be addressed operatively to allow the ulnar collateral ligament to be repositioned deep to the aponeurosis so it can heal. Some suggest that one can diagnose a Stenner lesion clinically by palpating the area of injury and feeling for a lump. This can be quite difficult, especially in the presence of swelling and tenderness. Similarly, ultrasound and MRI scans are not necessarily reliable in being able to diagnose the presence or absence of a Stenner lesion. A Stenner lesion can only reliably be diagnosed by direct vision at operation. The treatment plan is as follows. If there is an endpoint, that is to say that the ulnar collateral ligament has been incompletely ruptured, it is reasonable to immobilize the MCPJ for 6 to 8 weeks to allow complete healing of the UCL, followed by graduated mobilization. If there is no endpoint, that is to say there is demonstrable instability on radially stressing the MCPJ of the thumb, then one has to go on to open repair, because this, as we've said before, is the only way to ascertain if there is a Stenner lesion or not. At operation, the proper ulnar collateral ligament is reattached to the bone, the accessory UCL is attached to the volar plate, and the dorsal capsule, as it is often injured, is repaired as well. I hope you have found this presentation useful. Thank you for watching Medicine in a Nutshell.